Good morning and welcome to our third webinar for first responders leaders. Today's topic is returning to work from a psychological injury, challenges, and recommendations. My name is Trudy Rondeau, and I'm the chair of the BC First Responder Mental Health Committee. I'm also really excited to be the moderator for all 6 webinars in the series. For those who attended the sessions in January, the next minute or two will sound familiar as I repeat some information provided previously. However, there are enough attendees only attending specific sessions and not the whole series that I want to repeat our committee's introduction. Since its creation in 2015, the BC First Responders Mental Health Committee has worked to support positive mental health by creating and sharing best practices through resources, awareness campaigns, training, and education and supports that first responders, their communities, and their leaders need. The committee includes representatives from law enforcement, firefighting, paramedics, and dispatchers, as well as the provincial government and WorkSafe BC, and is proud to have shared its resources with organizations across Canada to promote awareness and to attack the issue of mental health stigma head-on. In January 2019, the committee successfully hosted its first 2-day BC First Responders Mental Health Conference in Richmond, BC. 350 delegates came in person to listen and learn at the sold-out conference, with 98% of attendees saying they would attend another future BC First Responders Mental Health Committee conference. An encore was planned for January of 2021. Fast forward to today, where the plans for the 2021 event had to be reimagined. And as have many other organizations over the last year, we switched to a no-charge virtual format, allowing us to accommodate many more attendees than we could have imagined hosting in person. However, the goal remained the same, to deliver an event that would be of greatest value to this community, because as perhaps in no greater time than before, the challenges relating to promoted positive mental health in your community have never been felt so acutely. Today's session is 90 minutes long. We'll have some introductions and then a brief presentation from each of our 4 speakers. This will be followed by a question and answer period consisting of both moderated and audience-driven questions. So please, I encourage you to use the Q&A feature, not the chat, to submit your questions throughout the panel discussion. Don't wait until the end. And please use the thumbs up feature if you see a question that you like. Now, there are approximately 1,000 people who registered to attend this webinar, so we may not have an opportunity to get to all your questions, but we do have a team member actively curating the questions during the session so that we can address the most common themes. In terms of our audience today, there was interest to participate from across various first responder communities and from across the world. 70% of you indicated that you're in a leadership role, 37% are from law enforcement, 32% from firefighting, 15% from paramedicine, 4% from emergency dispatch, and 11% of you fit into the other category, which includes clinicians, therapists, chaplains, and members of local government. 51% of you are from the Lower Mainland, but we do have almost 84 people from other provinces in Canada and several people from the US and the UK. Before I move on to introduce today's speakers, I would like to acknowledge that we're hosting this session from the traditional, ancestral, and unceded territory of the Coast Salish people, including the Musqueam, Tsleil-Waututh, and Tsawwassen people. Also, please note that these sessions are being recorded and will be posted to our speakers event series website, conference.bcfirstrespondersmentalhealth.com, within a couple weeks from each session date. The links to sessions 1 and 2 are now available if you missed them, or if you want to view again or share with your peers. So some more on our subject for today, returning to work from a psychological injury, challenges, and recommendations. As you listen to the presentations and then the dialogue, you'll hear diverse perspectives offering a unique look into the return to work process. By the end of the session, you'll understand how to differentiate between physical and mental health injuries. You'll gain an understanding of remain at work or stay at work as it relates to mental health injuries. You'll learn how to develop and implement a return to work plan for mental health, and you'll understand how to navigate setbacks and set expectations for the parties involved in the return to work process. Finally, I want to encourage you to be mindful about the next 90 minutes. You've made the commitment to attend, and you're here now. Please put your distractions aside and focus on the information that's being shared with you. Our goal is that by the end of this session, you'll have some practical information to help you in your leadership role. On to our speakers for today. I'm very pleased to introduce Diana Vissers. Diana has been solving workplace mental health problems for over 25 years in multiple industries. She achieved her Master's of Arts degree in Disability Management with a special focus on workplace disability prevention and mental health, and has developed many education and support tools, such as COVID-19 Psychological Support Toolkit, developed in partnership with the BC Municipal Safety Association. Diana has a special interest in first responder mental health. She conducts research and support in the first responder community in BC and provides in-kind services for the BC Professional Firefighters Association, where she serves on the mental health task force. Welcome, Diana. Next, I'd like to introduce Staff Sergeant Glenn Close. Glenn Close is in his 21st year with the Edmonton Police Service. He's currently in charge of the Resiliency and Reintegration Unit, which is a unique return to work program that blends peer support with confidence building exposure training for members after a critical incident or an injury. Prior to this role, he spent time as a patrol supervisor, firearms instructor, beat officer, and jet boat operator. And just last month, Glenn was promoted to the position of Staff Sergeant. Welcome, Glenn. Next, I'd like to introduce Captain Steve Farina. Steve began his career as an on-call firefighter with the Township of Langley Fire Department in 1992, and 5 years later joined the Coquitlam Fire and Rescue full-time. He was elected to the executive board of IAFF Local 1782 in 2005 and was promoted to captain in 2015. Additionally, Steve is a VP on the BC Professional Firefighters Association, which represents over 4,000 professional firefighters. He's a member of Coquitlam Fire and Rescue's Critical Incident Stress Team, and he serves as a peer support for his coworkers. Steve also chairs both the BC PFFA's Health and Safety Committee and their Mental Health Task Force, and he represents the BC PFFA on the BC First Responders Mental Health Steering Committee. Welcome, Steve. And last, I would like to introduce Allison Kennedy. Allison is a client services manager in the Mental Health Claims Unit at WorkSafe BC. She completed her Bachelor of Science in Kinesiology at the University of Ottawa, her Rehabilitation and Disability Management Diploma at Simon Fraser University, and is currently pursuing her Master's in Disability Management with a focus on work disability prevention and early intervention. She has worked in various clinical settings with a variety of providers and treatment programs, where she refined her focus on safe and durable early return to work outcomes. Allison is a member of the International Association of Professionals in Disability Management and holds the internationally recognized Certified Disability Management Professional designation. So without any further ado, I'd like to pass it over to Diana for her presentation.
Those who have a why to live can bear almost any how. Viktor Frankl wrote that in his book, Man's Search for Meaning. His quote is the perfect place for us to start our conversation today about returning to work following psychological injury. I'm rarely asked about why. Often I'm asked how do I get back to work safely? Or how do we design better return to work programs? Or how long should a person stay off work safely? Or how do we know this person won't get hurt again if we send him back to work? And I suspect that many of you that came here today for this session have a lot of how questions. And we are going to be answering some of those questions. But for a moment, let's just sit with why. First responders are deeply connected to their why. I'm really good at helping distressed people. Keeping people safe is in my DNA. It's not what I do as much as who I am. These are the regular sentiments that all of us hear from first responders. And so when psychological injury happens, it's one of the most frightening thoughts for a person, a first responder, that they may not be able to go back to being who they are. Not as much what they do, but who they are. Next slide, please. Work-related psychological injuries are not new. How we deal with them, though, has changed a lot. And our awareness of them, how we're responding as organizations and as individuals, all of this is changing. And change brings a lot of different responses. As you're looking at the words on this screen, I just encourage you to think about which of these words really resonate to you. Which ones connect you to your thoughts and responses when you hear or learn about a psychological injury, or maybe when you're concerned about a psychological injury. For many of us, our initial thoughts and our responses to psychological injury colors everything that comes after. It blurs our vision of solutions. It shines a light on the obstacles that are in front of us about that return to work for that person, whether it's us or someone that we're supporting. That's what needs to change. 2 years after the first conference, the Mental Health First Responder Conference, there's been a lot of change in the way organizations manage return to work, the treatment options that are available, the supports that are in place. But every single stakeholder in this equation still has a lot of work to do, all of us. Next, please. So what has the most impact on successful work return? As you're looking just at this question, I want you to think about what things come to mind for you. And I'm going to slowly reveal and talk just a little bit about each one. So first, next slide, please. So personal resilience, always this is the first go-to. The strength that a person has, their ability to respond, their ability to bounce forward after the incident. Yes, we know that this is absolutely important. Next, the magnitude and severity of an incident. So often we think about, how significant and severe the actual incident was, and this does play a role to some degree. Next, the level of support. And this is not just the level of support a person has in the workplace, it's also about the support they have in their life. Next, the treatment, whether or not they're getting the right treatment at the right time, definitely plays a role. And then finally, next, your response. So it's not just the person's response to the injury, it's the response of every person that surrounds that individual. So what do you say when somebody tells you, I'm struggling, I'm worried about myself? The response of the organization in terms of the policies and procedures they go through, whether or not they're connecting, whether or not they keep that person in the fold. These are all factors that have the most impact on a successful return to work. What might surprise you is that the order of these is not as they are displayed on the slide in front of you. It's the interplay between these that has the most impact, and every single person with a psychological injury has a different formula of what has really impacted them and what is going to impact the return to work. Next, please. So I've worked with a lot of different return to work scenarios, and I've been asked to talk about what is the most challenging obstacles to successful return to work. And so I looked to the research for this, but I want to talk a little bit too about my own personal experiences. Next, please. Uncertainty about the future is probably the most challenging issue when working with somebody and supporting them through a return to work process. So think about your own organization and what pathways an individual goes through towards that return to work. Is it clear? Do they know? Is there an option for them in the workplace if they can't do their own job? All of this plays to helping a person build the confidence that they might need. And when the uncertainty is prevalent, it really creates a big challenge for everyone. Next, please. Guilt and shame. Guilt and shame play a huge role in psychological injuries. In fact, the organization plays a key role here too, in helping individuals in how you respond to that individual, whether you're reinforcing that feeling of shame and guilt, or whether you're reassuring that person of their belongingness to your organization. Next, please. Lack of connection to the workplace. Cannot emphasize enough. I've heard it described by some first responders that they're feeling abandoned. that they have maybe not had a phone call in 6 months while they've been trying to navigate these systems on their own. And lack of connection, your way of connecting with a person may be different. It needs to be different according to what that individual's needs are. So for some people, connection might mean regular phone calls and email communication and contact, and for others it might look completely different. And who is doing that connecting can also have a difference. Next, please. And finally, workplace relationships. When there are workplace relationship issues, they really need to be addressed right at the front end. It can create so much fear and apprehension for a person coming back to work if there's unresolved issues in that work relationship. So really common scenario is if there's some disparity in their immediate work team or with their supervisor, and that person doesn't have any communication with that supervisor or that person until they actually step foot back in the workplace, that can be super challenging. Next slide. So we've talked about the challenges, we've talked about the impacts. Now I want to talk just for a couple of minutes about how you can actually create more success in your own workplace and through the role that you have. So whether you are an individual who yourself you're concerned about your own psychological health and safety over the course of your career, or you're a coworker, you work in the environment and you want to know how to support the people who you work with, or you're in human resources, or you're a staff sergeant in a police department or a fire chief. Whatever your role, these are the keys to you really helping improve the success and the outcomes that are there. And you know, probably in broad strokes, the biggest way of achieving all of these is if we really shift our lens so that we start to look at psychological injury the same way that we look at physical injury. And that means the same resources, the same training, the same mindset about this is health and safety. How do we create a safe environment, identify risks, and then deal and manage with those risks? Viktor Frankl provides another sentiment that I want to close with. Everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. Each one of us working with recovery and return to work from psychological injury chooses an attitude, a response to every circumstance we find ourselves in. And so I now challenge you to think about what is your attitude and response, and how can you impact on these things you see on the screen to really choose an attitude that helps restore the why. Thank you.
Thank you, Diana. That was an excellent presentation, and I think so much to unpack in there. Something that certainly resonated for me is at the beginning when you talked about this is who first responders are, this is their identity, this is who they relate to being. I think that that's certainly a common theme I've heard from all the first responders that I've worked with. So thank you very much for that. We're going to move on to our next presentation now. This is from Staff Sergeant Glenn Close. Welcome, Glenn.
Good morning. Thanks, folks, for letting me speak here all the way from cold, wintry Alberta. It's my pleasure to be here today, and I'm really hopeful that a lot of this dialogue is going to create some change there for public safety personnel in your province. I'm going to quickly get into just a really brief overview of our program here with the Edmonton Police Service as we look at working with our members after a critical incident or after a time away from work due to an injury. And then I'll flip into some of the considerations that we've seen here that are important for us to pay attention to when we're looking at helping these folks after these situations. So we can flip to the first slide there, please. So our reintegration program started in 2009. I was a firearms instructor at our range, and myself and my partner, we were asked to start working with members after officer-involved shootings. In the interceding 12 years, we've grown that program quite a bit to where we now have two streams or two tracks. The first track, as we call it now, is our short-term program. And the way that I describe that program is that is post event, pre-injury. So something's happened out on the street that's very impactful to our members, something that we would classify as a critical incident. What are we doing to help mitigate the long-term psychological injuries for those members? And how are we normalizing their reactions to things? And this goes beyond critical incident stress models. This is about rebuilding their confidence in the short term after that event, but before an injury occurs. And we do that by taking them back to the range, taking them back to drive in the police car, taking them back to work with control tactics instructors in the mat room and regaining their confidence as it relates to fights on the street. So our short-term program, working with members, like I say, post-incident, pre-injury, we work with members after officer-involved shootings, serious use of force events, serious on-duty collisions where they've smashed a police car or somebody gets hurt during a collision, and other types of critical incidents such as a SIDS death or other events that are quite impactful for our folks. And by allowing them to have a venue early on to speak about things and to steer the process and to rebuild that confidence, we're seeing a lot of health and wellness out of our folks. And we're seeing that post-traumatic growth occur even before we even get to the nature of or the level of an actual injury. Through the years, though, we've seen that not only can we work with our members after an event, but before an injury, we've certainly seen that there's a place for the reintegration program once our members get to that level where they're diagnosable or they do have some form of an injury, or if they came to the Edmonton Police with a concern already, whether that be depression, anxiety, concussions, and things like that. So that's known as our long-term stream or our long-term track. And we call it long-term because these folks are important to us and we're going to invest all the time that they need. And so what that might look like is we're working with folks, again, to rebuild their confidence after a PTSD diagnosis, suicidal ideations, or even suicide attempts. We also recognize that when members have been away from the street for a period of time, and we have lots of jobs off the front line, and if they're going to rotate back to an operational role, there's this huge confidence gap that occurs. Policing changes immensely week by week, month by month, year by year. And as soon as you're away from the role for a period of time on the street, like there's a confidence gap that occurs. So we've recognized that to help our members, we have to also build a program just when they're going back to the street, when they've been away from that frontline policing role for a number of years. And one of the areas that we're working on now as well, and this is important because we can go down the road of a moral injury or betrayal, is working with members with professional standards branch investigations or internal disciplinary issues. Those folks can feel betrayed by the organization simply by the way that the organization investigates these situations. So it's important for us to, again, rebuild their confidence and make them feel connected again to the organization. And that's something that Diana cued on. The connectivity to the organization, that's where we can help. So if we can flip to the next slide. Just some considerations for when we're looking at building programs with our members here in Edmonton. I think for the longest time, there was this belief that when members go off sick or injured, the organization says, okay, go away, fix yourself, and come back when you're ready. That doesn't cut it anymore. If the injury is based on the work that the member has done within the organization, then the organization has a duty to assist in that member's recovery. And we haven't looked at it like that way before. But what does that look like? It means that we have to properly, like was said, we have to properly engage other community supports. But I think peers play an absolute vital role in this because we have to bring the member back into the fold. And as Diana said, one of the concerns often that gets raised is there's no clear path. There's this uncertainty of how does this look going forward. As a peer doing a reintegration program, I can help set that path. I can speak with the member and say, well, what do you want to accomplish? Do you want to go to the range? Do you want to shoot? Do we need to do exposures back to police headquarters because police headquarters is causing you immense amounts of stress and anxiety as you look at coming back to the workplace? And so as a peer, through my employer, I play a vital role in helping bring our members back into the organization. Where this is really key is because, unfortunately, clinicians, as good of a job as they do, they just don't have access to our equipment. Clinicians don't have guns. They don't have body armor. They don't have police cars. When we look at this for other professions, clinicians don't have fire trucks. They don't have stretchers. They don't have ambulances. And so when we work together and we have a cadre of specially trained peers that are going to be in a position to conduct these exposure sessions, that's when we really show the member that, hey, your organization cares about you, and we're going to invest a lot in you in that path back. And that again speaks to the things that Diana was talking about relative to connection with the organization. When you dedicate peers that have a lot of autonomy to build sessions and rebuild members' confidence, that's when we see a lot of health and wellness with these folks coming back to the organization. It is about investing in the peers that are then able to actually really help with the exposures for our injured members. Right now here in Edmonton, we have full-time staff that work full-time in the reintegration program. And then we have some part-time staff that do this off the corner of their desk because they greatly believe in the work that we're doing. And that means we have instructors in firearms, instructors in control tactics, instructors in driver training. We have exposure therapy training. So we have special training from Dr. Meg O'Macahern in Calgary in terms of how do peers assist with exposure therapy sessions when their clinicians can no longer play a role, or can we do them together? And so I've done that lots. I've done sessions with clinicians. I've done sessions with occupational therapists where we throw the occupational therapist in the back of the police car and we go for a drive, we turn on the sirens, we drive fast. That's when we show that true connection between what the member needs, what the clinician can do, and what we as the workplace can do. It's about really bridging all three of those areas together. This is about rebuilding confidence. And in fact, I just kind of said that a couple of weeks ago, and I think I coined a new term for our program. We are in the business of rebuilding confidence. And if I can only sit and talk with a member, I can only rebuild confidence so much. This is about empowering peers to go out in the police car with members and rebuild that confidence on the street. It is about empowering peers to take the member to the range and rebuild that confidence on the range. It is about empowering people like me to bring a member back to headquarters and be that safe peer that can help with their exposure back to the environment that is police headquarters or the scene of a traumatic call out on the street, because we're actually allowing our peers to take on that role. We're not overstepping. I'm not a psychologist, but I'm a peer that's willing to do lots of extra training to actually help our folks come back into the organization. And we work really closely with our clinicians. It only works when we all work together. But we take a really, really heavy active role in that response and pulling our members back into the organization because we have that additional training and we have that ability to actually conduct those exposures and conduct those training sessions. And so that's where I feel we've seen a lot of success with the program that we have here in Edmonton. It's a quick blast. I'm going to flip the slide and my email is on there if anybody wants to send me a request for more information. Thanks, folks.
Thank you very much, Glenn. I personally am passionate about prevention, and I've had people ask me in sort of a disbelieving tone, you can prevent psychological injuries? And I love how your short-term program really focuses on, and the words you use there about mitigating a long-term injury. I mean, I think that's a fantastic approach, and this concept of early intervention makes such a difference when it comes to remaining at work or returning to work. So thank you very much for your presentation. I'm going to pass it on next to Captain Steve Farina. Steve, welcome.
Thanks, Trudy. So just building on what Diana and Glenn talked about, and there's a lot of common themes here about connection and collaboration. And you just mentioned about the stay at work option. And, you know, I think that is almost our go-to option, but it depends on a bunch of different factors, of course. And that's your organizational culture and where you are at. Do you have a supportive culture? Do you have an educated culture? Do you provide, good mental health benefits? And so if you have all those things in place, maybe stay at work is your first option. But also depends on where your first responder is on that mental health continuum. And are they in the orange or are they in the red? And that will kind of dictate, do you need to get some mental health treatment prior to them returning to work or staying at work? Or can you do that in conjunction when they stay at work and have all those protective factors of coworkers, keeping connected, as you said, to the workplace and still providing that mental health support? I think it's a great opportunity for leadership, to get upstream, and, return to work is a downstream piece. And the stay at work option, when you have people are in the orange, there's, they're just struggling a little bit. And if you can get to them ahead of time, get them the supports and keep them at work, we know that they're going to just be getting to thriving faster than they are surviving. I think that's something that's really interesting. So if you can accommodate them with no night shifts, modified duties, connect them to a peer, schedule them with a mentor, perhaps that's a trusted coworker. And of course, I mentioned connected to a professional. I think that's really a mental health professional would be very good. And then also maybe even considering filing a WorkSafe claim and getting healthcare services while they're still at work. So those are all options for that stay at work option piece. But, Diana mentioned about the difference between a physical injury and a psychological injury. And I think there is such a difference. And you see on my slide here, I've got, next slide here. And one more slide after that, sorry. Perfect. So we celebrate people coming back from physical injuries, shoulder injury, back injury, broke a leg, got shot. You're almost welcome back as a hero into your fold. But when you talk about psychological injuries, it's almost like, and Diana mentioned this, there's this guilt and shame and stigma surrounding that. And, as a captain, will my crew trust me to be making leadership decisions? And so there's all of these little factors that come into this returning from a psychological injury. The other challenges as well is this complex nature of our job. It's not something you can just get plunked back into an office setting. Glenn mentioned it, you've got body armor, you've got guns, for firefighters, can you drive the fire truck? Do you get triggered at the hall? What tasks can you do on a modified late duties kind of piece? So there is definitely challenges with being a first responder. So, returning to work, has to be an all hands kind of approach when it comes to return with a psychological injury there. So identifying all the stakeholders and making sure everyone's on the same page, that was the common theme that I heard from the other two presenters, is this spirit of collaboration. And I think that's really, really critical when it comes to returning to work. The other piece is you have to have so much more patience and empathy and have time invested to make it successful. If you rush it back, you are going to find people, if you push them back, and we were talking about this earlier when we were sitting in the green room there, is they will push back. So if you really are gentle in your approach, have great, emotional intelligence when you're dealing with these things, and, understanding that there may be setbacks, I think that's really, really critical when you're dealing with these pieces, and having a proper timeline, like 3 to 4 months, but having it an open timeline, because if they get triggered and set back, you're going to have, it's going to be dynamic. So each claim is definitely individual. Next slide, please. So from my experience over the last couple of years dealing with some of these return to works, I've seen the full spectrum. I've seen people return to work with no connection, no plan, no education from leadership or supervisors, perhaps, or no training. And the return to work was completely unsuccessful. And, you're setting someone up for failure. They have a psychological injury. It's an injury of the brain, injury it's almost, an injury of the heart as well. And, we talked about, we are, as first responders, it's so deeply rooted in our identity that we want to get back, we want to help, we love being first responders. And, there is that guilt and shame piece. So if you're not supporting them in a manner to return successfully, you're going to fail. And I think that's why, I put up here some ingredients for success. And for people that know me, I like to bake, I like to cook. And so, you have to have these ingredients to have, a successful return. And those ingredients are connection, collaboration, coordination, and communication. You already heard from the other speakers that these are integral to be successful when you come and have a graduated return. Next slide, please. So the connection piece, and we already talked about, it is absolutely critical. And if the person is off work, booked off sick, and we haven't quite assessed that it's a psychological injury, it can be very isolating as a first responder. And it depends on their home life, and if they're living alone and they don't have a lot of friends, and maybe the cumulative stress of the job has really impacted them, and they need to take a knee and they booked off sick. They're very alone. And if you don't have people reaching out, whether it's a peer, a supervisor, or anybody, perhaps it's a union representative reaching out, checking in on them, it's almost like a lost soul. And I think Diana mentioned that, is that connection is so critical to keep them part of the organization, to keep them at work perfect. But if they are off and they are struggling, it's imperative that we have that and maintain that on a regular basis. It's not, and it is individual. Maybe it's once a week, or maybe it's every single day in the beginning, and then it peters off, and then you're just in a supportive role. But that piece is so critical. Having an empathetic organization and culture, you identify those issues early and you can nip it in the bud. And we've been finding that with our peer support team, is that we're seeing people, just really subtle shifts, and you find that they're withdrawn, or they're not participating as they were before, and we can nip that in the bud. So if you have that culture built in, it's great. You can get ahead of it. But what we've been also finding is, because we're more connected with our peers and people are talking more, and we're sharing it and wearing it, sharing it, not wearing it more, we're finding that people are more willing to put up their hand, ask for help, remain connected, and that's really important ingredient for that successful return once they do come back. So I mentioned utilizing peer support. The one thing we've learned through my experience is assigning a worker rep to advocate for them. This is not like a physical injury where they can advocate for themselves. They're in a sound mind. It's, I just broke my leg, I'm going to come back. When you have a psychological injury, you interpret things differently. Your perceptions are different. And having someone, clearly communicating with the supervisor, the fire chief, or whoever you deal with, and speaking on their behalf is really, I found, been very get a lot of success with that, because you can interpret and communicate and clarify things more so than someone that's actually still struggling with an injury. And the other piece too, if you can, is keeping the family connected and informed. And I think, home is ground zero with a lot of first responders when it comes to trauma. And I think finding that if you can communicate to a spouse or a trusted person or, support person, and have them part of the solution, and mention that, checking in on them and say, how are things going at home? Do you need any support yourself? Because, trauma seems to be, there's a ripple effect. If you're injured, your family's also experiencing that trauma as well. So I think that's a really critical piece. Next slide, please. So the collaboration we've already talked about, I think it's so critical to get everybody on the same page. And you'll listen to Allison next. And we've worked together on things, on a few return to work successfully because we collaborated. And I think that's really critical to identify the stakeholders. And that's whether that's a case manager from WorkSafe, your human resources folks, a worker rep, a union rep. Of course, the worker is going to be part of this plan, but also the crew or the division staff. They need to know the plan as well. Everybody needs to be on the same page, so that spirit of collaboration is absolutely critical for success. And there needs to be some training around that as well. It's not just, you can't just expect people to know how to have this return to work piece work. And I think that's a really critical piece on this, is giving them mental health first aid or some sort of training and how to navigate these psychological injuries and the return to work piece. Because if you don't have that training, how are you going to have that empathy, patience, and understanding of the process? So that's a really, really critical piece as well. Okay, next slide, please. So the coordination piece, returning to work in a public safety setting is extremely challenging. As I mentioned, it's very complex. So you have to build realistic schedules. You've got to integrate achievable goals. And it can be a college graduate return for a reason, because you're slowly reintegrating back into the work. I love the work that Glenn is doing. It's including the worker in that plan. And I think it's really important. So that coordination piece is really critical. Next slide. And so lastly is the communication piece, and is vital throughout the whole process. This will assist with all of the other goals necessary to be successful. You got to communicate with all the stakeholders, family included if applicable. Make sure the goals are understood, clear, and concise. Use empathy, be kind, and communicate in a supportive manner. And avoid ultimatums and pressure tactics that try to speed up that process. Just be patient if I say anything. And because it's psychological injury, your body language, facial expressions, and the words you choose matter. So be aware and use your emotional intelligence as a leader, and you will be a lot more successful. I guess, and lastly, if I can leave you with anything for your ingredients for success, is remember that your greatest asset is your worker, and don't treat them like a number. Treat them with respect and dignity, and treat the whole person when you're talking about return to work. So that's all I have for you.
Thank you, Steve. You raised an interesting scenario. What if it's somebody in the leadership role that's returning to the work situation, and how do you ensure that you've got the trust of your team in that situation? And I think that's a really interesting dynamic, and maybe we'll explore that a little bit more in the moderated session that's coming up. So thank you for pointing that out. Last, I would like to welcome Allison to the screen with her presentation. Welcome, Allison.
Morning, everyone. So prior to discussing the importance of the stay at work concept while an employee is recovering, I'd like to briefly highlight the differences between a physical injury and a psychological injury, and most importantly, convey that both types of injury require workplace interventions and supports to ensure a successful return to work outcome is achieved. Next slide. At first glance of this slide, one can easily identify that a physical injury can be observed on the left-hand side. However, the symptoms associated to a psychological injury can be easily identified as an employee being disengaged, angry, fatigued, and deterred. Too often, employers consider struggles with sleep, the stress of everyday life, and our mental health to be personal issues, and they simply don't want to intrude. For example, the colleague on the left who comes to the hall on Monday morning, they'll be asked if he's okay, what supports are required to assist him while he recovers. On the other hand, the colleague on the right, who is typically engaged and upbeat, walks into work on Monday and presents as quiet, disengaged, and fatigued. The comments he may hear, "What's wrong with you today?" or "Cheer up." And oftentimes, this may be the extent of the conversation. In reality, this colleague with a psychological injury requires the same extent of support and interventions that were provided to the employee with the physical injury. Next slide, please. Now that we have a clear understanding that psychological injuries also require early support interventions, I'd like to discuss the importance and value of a positive corporate culture in order to assist employees with their recovery while they remain at work. Next slide. So this slide is a disability prevention model, and as you can see, the nucleus is the positive workplace. And so as first responders, you may be thinking to yourself, how do we even prevent this, right? Your job is to respond and be exposed to abnormal human situations, confrontational situations, and threats to life. How can we actually prevent this, Allison? The scenes and traumas you're exposed to cannot be prevented. I agree. However, the impact of those traumas and exposures can significantly be minimized if properly mitigated. In addition to your critical incident stress debriefing and group supports, a paradigm similar to what you see on the screen is imperative to ensure employees are able to remain in their first responder roles until retirement. So the first component of this model is early identification. Identifying early warning signs is key to ensure the employee is provided with all the appropriate supports and interventions to recover while remaining at work. For example, an employee demonstrating high or low moods, excessive worry and anxiety, anger, aggression, all of a sudden socially withdrawn, and increased absences are signs to look out for regarding an employee's well-being. A second component of this model are prevention programs. Make mental health self-assessment tools available to all your employees. Ensure that all employees have readily available access to mental health resources and crisis lines. I highly encourage that this is part of the orientation for new staff, as well as a refresher for existing staff. Host seminars or workshops to discuss strategies to address early signs of psychological injuries, and most importantly, provide leaders with training to help them recognize these signs and symptoms. The third component are health promotion programs, all of which employers have in regards to employee family assistance programs, but also think of a way to introduce workplace wellness challenges and geared towards the employee interest. And the last component of this model is the active health and safety philosophy. So a well thought out policy statement will give the company philosophy and commitment to early and safe return to work. There's significant reluctance to seek help or treatment due to a persistent stigma surrounding mental health. But as leaders, it's your duty to erase this stigma by expanding your cultures of safety to include the prioritization of mental health wellness among staff. We would never ignore any other dangerous hazard, and this should be no different. Once the incident or illness has occurred, many strategies can be used to get the employee back into the workplace, but none are as valuable as preventing the medical absence in the first place. Next slide, please. There are a number of community resources of which employers and OC health and safety practitioners need to be aware of. These national resources are available in both official Canadian languages, with most of them being freely available. Next slide, please. There are 10 cornerstones of disability management, and I will not be discussing all 10, but there are 2 that I would like to highlight as they relate to the stay at work concept. Next slide, please. So the first cornerstone being early intervention. As we all know, despite the employer's many efforts to implement preventative programs, injuries in the workplace will unfortunately at times still occur. And the implementation of effective early interventions is key to ensure successful stay at work outcome. The period of post-injury has actually been referred to as traumatically induced unemployment. It is important to understand that individuals who are away from work due to an injury undergo similar reactions and consequences as people who are unemployed due to a plant closure. Results of many studies demonstrate that work is part of establishing and maintaining a healthy identity, and that prolonged employment can lead to severe psychological distress as a result of loss of work identity, loss of social support, and loss of daily routine. However, I will highlight, like Steve and Diana and Glenn have highlighted, the early intervention should occur prior to the employee leaving the work site by conducting a check-in with the employee with the intent to intervene early enough to be able to implement those supportive measures and resources. So for instance, it's not a complex process. It's initial contact with that employee. What supports are required to remain at work? And they're all going to be different depending on which employee you're dealing with. But explore modified duties, light duties, alternate duties, changes to the schedule, such as hours and days, as well as ensuring that your staff are aware of the community and employer resources that they have. So for instance, employer resources would be their extended healthcare benefits, EFAP, online resources, as well as WorkSafe BC. Second example would be provide supports for submitting forms to WorkSafe BC. The worker can remain at work while they receive healthcare benefits. As well, maintaining ongoing contact. Ensure that the employee understands that you are there to help them with their recovery and return to work, and they are a valued employee. And I can't stress enough that this is not a one and done approach. You need to follow up with your staff. By completing these steps early in the process, you ensure that the person feels valued, is expected to return to work, and will be assisted in their recovery process. Next slide, please. Time is of the essence. The reason for prompt attention is that after 12 weeks of absence from work, the chance of the employee returning to work is reduced by 50%. This percentage actually decreases significantly as weeks pass by. By 24 weeks, the percentage of employees that return to work post-psychological injury is found to be 20%. And at 48 weeks, 2% of these disabled employees return to work. Research demonstrates that organizations demonstrating the best results in return to work outcomes begin early interventions by day 1 of an occupationally related medical absence. Of course, as Steve has highlighted, there's such a thing as too early intervention in some instances. It's imperative that interventions occur at the correct time, but as early as appropriate. Early interventions require an individualized approach, individualized to the person, their functional abilities, their rehab needs, their employment situation, and their workplace needs. Next slide, please. The second cornerstone of disability management I want to discuss are accommodations. So as you can see on this slide, we need to find a balance between the employer needs as well as the employee needs to ensure that the accommodation is successful. Most frequently than ever before, Work sites are receiving requests to accommodate employees with mental health injuries. The accommodation requirements will vary significantly than those with typical physical difficulties, and more creativity and flexibility is required, but it can still be done. It's important to remember that regardless if it's a physical or mental injury, we must focus on the employee's abilities and function rather than the diagnosis itself. Many individuals can facilitate the gradual return to work process. However, regardless of who's involved, a successful gradual return to work outcome depends on a cooperative and collaborative approach between all stakeholders, along with continuous monitoring of the employee's function and progress. This will ensure that appropriate revisions are made in a timely manner if it's necessary. In order to avoid delays in offering suitable accommodations to the employee, I highly recommend that a modified return to work or alternate work job bank be created by the employer. Examples of accommodations for people with mental health injuries include flexible scheduling, and as I mentioned on previous slides, modified duties, light duties, alternate duties. Even if this is a WorkSafe related claim, supernumerary basis, having them as an extra worker to help with those exposures as well. Working from home intermittently, COVID has definitely opened a lot of options for us. So maybe they can do some coursework from home as well as going to the hall for exposures. Different work sites, different departments, different units, and this may be temporary or it may be permanent. Frequent breaks, private workspaces to reduce distractions, use of calendars or electronic organizers, and lastly, having the employer documenting those expectations in writing so the employee has that. Next slide. Our first responders come to work every day to ensure that our communities are safe. In return, it is our obligation to ensure that we can continue delivering these exceptional services by providing them with a supportive and healthy workplace. So my question to you is, how do you provide support in the workplace? Thank you.
Thank you very much, Allison. I really appreciated how you pointed out that exposure to the traumatic incident is probably not preventable in a first responder world, but the impact that that exposure has can be preventable or can be mitigated. So a really important piece. So we're going to move on to the moderated component of this seminar. So I'm welcoming all of our speakers to the screen. Diana, the first question I have is for you. As a practitioner, what's the most challenging part of the return to work process for you?
That's a great question, Trudy. For me personally, as a practitioner, there's lots of challenges. I find it actually really hard to watch people struggle. And so that's difficult. But I think in this arena, one of the most challenging parts is when it is so clear that there are solutions, but the different stakeholders can't see them the same way. That is very challenging. And so it might look like a process that an employer has that requires, before they can go forward in the accommodation process, they need the clinicians to provide certain information. But the individual actually needs to know now what the future is. So these different stakeholders, they're not seeing the same, their processes don't align with what the person needs. That's probably the most challenging piece.
Thank you. It certainly sounds challenging. Something Diana alluded to there, Steve, is the impact on herself as a participant in this process. Now, Steve, you're in a leadership role, you're a first responder yourself. What do you do in terms of your own self-care?
Yeah, that's a good question as well. As an advocate, and I'm much like Diana, it's really hard to see people struggle in these roles, and that becomes quite heavy. And I've just found that very recently, as of like Monday, I've had a couple that are coming to an end. One of our fellas was struggling, and you take that on, and so I make sure that I'm impeccable with my own self-care. And I try to be an example, like model good behavior. I go for lots of hikes and walks and, take good care of myself. I'm very cognizant of my sleep. So, practicing all the things that we preach is really critical when you're in these roles, advocating and helping them return to work. So you want to model that good behavior for them as well. Thank you.
Thank you, Steve. Glenn, there's certainly lots of interest in your program and the questions are coming in from the audience. But one of the ones that I have for you is, how do you measure the success of your program?
It's a great question. And in fact, our Chiefs committee asked that exact same question of us yesterday. And what's been hard is to not personally feel that success or failure is based on a member getting to a certain point within our organization. My role is not to get this person back to patrol. My role is to help them attain whatever goals they have. Because for some folks, their goal may be to never go back to patrol. So it's a matter of really building trust with the members that we work with and helping them get to their goals that they have. Beyond that, we look here in the Edmonton Police Service, because our area is kind of nebulous in terms of quantifiable measures. We look at uptick. Are we having people come through the door? And we are. What's our engagement levels? And that's where I say we have a lot of referrals coming from different sources. And when we have lots of members coming to us asking for reintegration services, I think that's the measure of success. Are people coming to us for help? Are people engaged? And we see that here. And so that's how we measure success here is, do we have people coming through the door? And yes, we do.
Thank you. I think you raise an interesting concept. I think that there's often the perception that a successful return to work means the individual goes back into the same role that they were in prior to their injury. But you've explained some situations where if that isn't their goal, then that's not achievable. It's whatever their goal should be. So Alison, a question for you. Can a successful return to work for a mental health injury always happen?
Well, for you, like for the people who know me, and Steve will chuckle here, I truly think that individuals who have a mental health injury can return to work. But to your comment, Trudy, it might not be to their pre-injury job duties, but I truly think because the employer has that duty to accommodate and to explore suitable accommodations, that the majority of individuals with a mental health injury should be able to return to their employer, for sure.
Thank you. Diana, would you like to weigh in on that one as well?
I'm going to 100% agree with Alison. And I think this is a really good example of the challenge that you asked me about. What I find challenging is that when an organization's processes and timelines for the return to work process don't fit, then sometimes that option of being in the same environment, the same workplace, gets taken off the table way too early. So for example, there's timelines with the WorkSafe claim. How long how much work is invested in treatment for a person? And at some point we start to wonder, are they going to make it the whole way? Are they going to make it back into their own job? And when most times there's a path back into that occupation. And when it isn't possible, then having different options available makes it so much smoother. Person can feel like they're looked after. We got your back. We're going to help you and be with you, and we're not going to abandon you. We're going to find a fit for you.
Thank you. Glenn, question about your program. There's often stigma attached to a mental health injury. Do you think your program has done things to alleviate that stigma? Can you talk about that?
Absolutely. And where we're quite lucky is this program actually started at the range with firearms instructors. And I think with the credibility of being a firearms instructor, it led for us to create different conversations. If programs are led from a mental health perspective, sometimes those can get storied off as well. It's always those people, they're always saying the same thing about mental health and things like that. And so the message can get lost based on who's delivering it. And I'm not saying we don't still try, but I'm saying is within any organization, if you were going to decrease stigma, you need to get people on board that can give messaging to the organization that have high levels of credibility. And so for us, we engage a lot of team members here in reintegration that are from tactical, from training section, from operational roles. And when we're the ones that are giving those messaging or those messages, that's how we are decreasing stigma. You need credible people that is going to have the ear of the organization to decrease stigma. And we've certainly seen that here within the EPS, absolutely.
Thank you. I mean, I think really what you're talking about is building a culture of support and trust. Diana, could you speak a little bit about the importance of culture in return to work?
Well, culture has such a big role, and it can be a really hard concept to swallow. I think the individuals who are involved in planning return to work, if you talk about culture, it's like, what do I have to do with that? How can I change it? It feels so hard. But culture can be the most influential factor. So if there is culture where where we don't see frequent return to work, when people leave the profession, they leave their job for psychological injury and they don't come back. That's the legacy, that's the culture in the organization, is once you're gone, you're gone. Very difficult. You imagine you layer that with an individual's feelings of guilt and shame and their own fears about their recovery and their loss of identity, and it becomes very complicated. And the same way, cultures where the first words a person hears when they tell someone at work that they're concerned is, I'm with you. I'm sorry you're going through this, and I'm going to be with you each step of the way. I'm not exactly sure how this is going to turn out, but I'm going to help you and make sure. That can have a very profound impact. And so, every connection, every contact an individual has with the workplace speaks to the culture and impacts on what happens next for them.
Thank you. Steve, I think in your presentation, you mentioned the significance of family during this process. Can you speak a little bit to that?
Yeah, I know, just kind of building on what Diana said, like we do some spouse education, family education nights, and having them understand the neurobiology of trauma, the exposures that we have, like the challenges that we have as first responders, and how they not only support the first responder and the family, but how the first responder can interact and reintegrate with the family after coming back from a call, a tough day. And having that, that communication and understanding is really critical for that family piece. Just building on that culture is the peer support. And I keep coming back to this, is what we're finding is that is literally changing the culture. It's providing permission for people to speak up. We've had family members reaching out to those peer supporters saying, hey, my husband or wife is struggling. Can I get resources? What do we have available? So there's so many pieces that can change the culture like Diana talked about. And it starts with good leadership, and it starts with education of everybody, all the way down to the junior person, all the way up to the leadership. So if you don't, there's so many components that you need in place. But yeah, family, educating them and bringing them in and making them feel part of the firefighter family or the first responder family is really critical as well.
Thank you. Glenn, does your program have any component or connection with family?
It does, especially after officer-involved shootings, because there's so much concern and worry on the part of the families afterwards. And the difficulty we find, though, is we really make sure we recognize that members themselves are the front door to the family. And so we don't inject ourselves into members' families. Cops are actually pretty private. And so we have to get the members' buy-in on the front end to allow us to engage with the family. That's where it comes down to trust. It comes down to building a lot of trust with these folks in a short period of time so that they understand, okay, well, we want to help you, we want to help your family, but we can only do it if you allow us to. And so we've opened that door that when members have gone through an officer-involved shooting or some other critical incident, or they're on the path back to work after an injury, we absolutely open the door for us to sit and meet with the family and pass along a lot of information as well. So we open the door, but recognizing we can't inject ourselves into a family if the member doesn't want us to.
Yeah, absolutely. Thank you for that. Allison, question for you. If you reflect on the most successful return to work that you've participated in, what do you think made it a success?
He's looking at me there. So I can think of I just started in the unit in mental health claims as a manager. And then I received a call from Steve, and it was quite a complex claim. And it seemed like this person was now going to probably go to vocational rehab, simply just because we weren't seeing a light at the end of the tunnel. And that sometimes is the best step for an employee. But Steve called me, he's like, no, we need to make sure that this person can be a firefighter. This is what they're meant to do. And I looked at the file, and all it was we required more collaboration. It took a lot of return to work plan meetings. Steve and I attended as well. And we made sure that everyone was on the same page, same goals, and we were well aware. And I think with this individual was the stress that what if I don't meet this deadline on the goal, on the return to work plan? And it was just communicating that it's okay. This is not set in stone. We can revise and support you until we get you to your end goal. And the worker is back at work and it's great. But again, just a story, but it was more the collaboration and the transparency. I know we talked about a lot of collaboration today, but I think the key word too is transparency, and everyone needs to know what we're working towards as well. So there's no hidden agenda as well.
Yeah, thank you. Thank you very much. Diana, would you like to comment on the concept of transparency in this process?
Wow, I think transparency is everything. With privacy considerations, I want to just say that that is a very distinct difference in psychological injury from physical injury. The discomfort for the individual in having their stuff shared and open with everybody. I really see transparency in process, approachability, clear communication, but giving that person the privacy of having their own internal experience with their recovery and their injury. And transparency can go a very long way. And so interesting ways that transparency shows up or doesn't show up. One of the ways it doesn't show up is when your return to work processes don't involve the key players who are going to impact the most on the return to work. And I'll give you an example. If the supervisor who's going to be working side by side with that person coming back is not involved in the return to work process, that's not a transparent process. You're actually not engaging all the right people. So that's just one example.
Excellent. Thank you. Thank you, Diana. So we're going to turn to some questions that we've got from the audience now, and there are a number of questions that have come in. So obviously lots of interest in all of the things that you've had to say. Glenn, I'm going to start with you. How much input does a member have regarding the timing or start of the reintegration program and the program overall?
I'm going to have two answers to that. When we look at the short-term program, we want our members coming back to work after, let's say, an officer-involved shooting within 7 to 10 days after the event. What we find is members want to come back to the normalcy of work. And so in that regard, we try to give our members as much control over the timelines as possible, but know that we're always struggling because when we do a short-term reintegration, like we have to work around schedules at the range and schedules with instructors and schedules with their chance to speak with their lawyer and our union and our provincial investigative body. So there's a lot of factors that play a role early on. But again, it goes right back to something Diana said early on about the uncertainty of what the process is going forward. So as long as we explain why there might be delays in the process, then our members understand and they're a bit more flexible in terms of their own timelines because they know why things are happening the way that they are. In terms of our long-term program, it's wide open. I consistently will tell our members, you have the control here, you're driving the bus. And then it's up to me if I need to convince WCB for an extension or if I need to convince the workplace for an extension, it's up to me to help bridge that communication. And that comes down to the trust between myself and the member. What I see often is our members want to come back to work, but they don't want to get pushed. And so we balance that all the time with our folks. But at every turn, we try to give as much control as we can to our folks.
Thank you. I love how this theme of trust has come out in the conversations and how important it is to have trust in all of the relationships that are involved in the return to work process. Diana, the next question is for you. Would it be reasonable to state that each return to work is unique and should be focused on the specific needs of the individual? If so, how can leaders best support the decisions of the injured individual regarding their reintegration and guide them to the best outcome?
That's a really big question. I might have to ask you to repeat part of it, but awesome question. And yes, yes, and yes. So every return to work is very unique. So I really caution against having a cookie cutter approach to particularly with psychological injuries. Like we know with MSIs, there's certain patterns of return to work that seem to work as you reintegrate. Psychological injury is a completely different scenario. And so the best way leaders can ensure that happens is by, first of all, making sure that that individual is getting the right kind of support to know what they need. Because what they want to happen needs to be balanced with their recovery process. Return to work is a part of recovery. They don't get better and then they go back to work. They actually need to be in that work environment to finish and complete the treatment work that was started before they stepped in the door. So leaders can make sure that process is happening in the right order. They can ensure that the people who are communicating with their people are asking the right questions and saying the right things along the way. So things like, what would be an appropriate next step for you? What would you like to see from us? And the leaders can lead by example by using those same rules when they conduct themselves.
Thank you. I'm involved in this conversation a lot, but I had a bit of an aha moment there, just the way you framed it, that returning to work is part of the recovery process. It's not that somebody is recovered and now I return to work. It's this process of returning to work is part of my recovery. I think that's a really key thing that you stated there. Thank you for that. Glenn, next question for you. What's the makeup or membership of the resiliency team at Edmonton Police?
So again, 2 answers. We have a dedicated section here that just looks after member wellness. And within that section, we have 9 full-time staff that have different portfolios. And that could include CISM, that could include member support, that could include our chaplain, and that includes our reintegration unit as well. So we have a section that is dedicated just to looking after the mental health of our members. An extension of that unit or that section is we have 2 groups of volunteers that are out in the EPS doing their regular work that we rely on when we need them. One group is our overall CISM team that reaches out to members after a critical incident. And the coordinator for that role sits here in my section, and that person sends out the CISM contacts to the volunteers out in the unit or out in the organization when we need them to cover off work for us. And then we have our volunteers, I'll say, that are also in our reintegration team as well. So while we have 2 full-time reintegration members here as a sergeant and a constable, we have our volunteers that are on the team that are out doing their regular jobs that are also doing reintegration work. The makeup of that team is we have, I think, 7 or 8 of our SWAT members, our tactical members that are on that team, several people in our training section that have their full-time job is to train in firearms or control tactics or shoot or driver training, but do reintegration work off the corner of their desks. We have 1 member in homicide section. We have several members in patrol. So we try to create as much diversity as possible in our reintegration team so that whenever a member needs an individual program built for them, and that goes back to the last question, is we have to build individual programs for our members. When we do that, then I can tap into whomever I need, whether that be a firearms instructor or whether it be somebody from tactical section. I can draw from people that we know will be relevant to the content.
Excellent. Sounds really comprehensive. I mean, you've done a fantastic job of building the network that you need. So excellent. Steve, I'm going to ask this next question of you. What role might chaplains or spiritual care providers play in this process?
I'm so glad you asked that, because when Glenn talked about that spiritual component in the fire service alone, we have the BC Fire Chaplaincy Association. So in my department, we have 2 guys in those roles right now, and ironically, one coordinates our peer team and one coordinates our CISM team, and so they also provide spiritual support for those members that are religious or just believe in something or need that kind of support. So I think it is critical. It's a component of an overall mental health program. I don't know about the paramedics, but you definitely have lots of chaplains in the police service for sure. And yeah, it's integral. For funerals, weddings, when we memorialize our folks that die in the line of duty, like those are all really integral. And then also for the return to work process as well, like relying on them for that support is really it's very helpful too.
Thank you, Steve. Allison, this next question's for you. I'm returning after being away with a mental health injury. Was wondering if there are certain things that should be avoided. Our organization does not have a standard approach to returns. My failed attempt made me more conscious for this present return to work.
Can you repeat, are they back at work, Trudy?
So I'll repeat it. It says, Allison, I'm returning after being away with a mental health injury. So they're returning after being away. Was wondering if there are certain things that should be avoided. Our organization does not have a standard approach to return to work. My failed attempts made me more conscious for this present return to work. So it sounds like they've had a failed attempt and now they're attempting to return to work again.
Right. So my recommendation, again, there's no cookie cutter approach, regardless if it's physical or psychological. I always think that the return to work should be tailored to the individual's actual abilities and their current needs. So if my only recommendation without knowing all the information would be to follow up with your supervisor, your employer, whoever you have contact with, and really share your concerns, because share that you want to be successful. You've had a failed attempt. So there's some concerns there right away that would be very worrisome. And I think it's all about communication, right? Your employer might think, and the provider might think this is a perfect plan, not knowing that you're feeling this way. So just communicating with who you trust, your provider, your employer, but we all have to be on the same page. My recommendation would be to have a return to work meeting with all stakeholders and really share on how you feel, because there's really no point of having a plan designed for you if it's not going to work for you.
Excellent. Yeah, I think there's that, I'm kind of repeating a message here, but how important it is for the worker to be involved in the plan that's being designed. You can't have a plan designed for you. You have to have a plan designed with you. I see Glenn nodding there. Thank you. Steve, the next question is for you. In speaking with colleagues who've been off work due to psychological injury, some needed help, whether clinically or administratively, but didn't know they needed it and didn't know they had to ask. How can we build a solid chain of support so that the ball doesn't get dropped?
Yeah, that's setting up a culture of connecting to support early on. I think that's the real critical piece. So you have the whole upstream approach, but if there's, if someone is going to report a work-safe claim or book off sick, we want to make sure that they reach out to health and safety committee member, CISM member, peer support, the chaplain, whoever. So it's really important to do some education and awareness around that, to say, hey, if you're going to do this, these are the people that you need to talk to so they can advocate for you. And like in my own department at Coquitlam, I asked if you would like me to be the worker rep so I can advocate for you and be in part of those conversations that Allison talked about. It's super critical to have that third party piece. So to be successful, you have to build that into the culture ahead of time, and then provide that education to those folks that are providing that service. So whether it's through the Workers Advisor's Office, getting training so they know how to navigate the WorkSafe process, that they're connected at a labor management level so they can talk to management and navigate HR and all those things. They have to have an understanding of all those moving pieces to really support the worker, and then the worker needs to be able to have that trust. And I think we've been talking about a lot, is trusting that someone's going to have your back while you're going through that process.
Excellent. Thank you. Oh, sorry, Diana, go ahead.
Yeah, because I actually had another thought to that question around a person needing to come forward to ask for help. And I actually think the most robust prevention programs include multiple pathways for people to have access to appropriate care. And so that means not requiring that your first responder come forward and say, I'm struggling, that they actually have options for mental health expertise to go and check themselves out, go and have somebody check in. Is what's going on inside my mind okay? Am I needing something different? Before they need to come forward and become public with the organization. So I think there's a real room there. Leaders ask that, someone leader asked the question, there's another thing that you can do is have multiple pathways that don't rely on that person disclosing in the workplace that they're worried about themselves.
That's excellent. And that's a great segue to the next question we have, which is on the same theme, which I'm going to direct to Allison. Early intervention is a great concept, but how do you get the employee to identify or admit that they have an issue? Leaders see changes in the individual, they just often don't want to admit it.
Right, and that's a great question. So part of that disability model that was on that slide was the early identification as well. And that comes with self-awareness. I know that first responders are very, very small. And it's very hard to admit that you may need help. I get that, because you're programmed to help people, not ask for help. So having those resources, like I had mentioned during the not the safety orientation, but the initial orientation for new staff, and having annual refreshers for your staff to remember where to find these resources, right? Because after a few years, you might not know, resources might change, but then they can access this from home. Right? There's also online CBT programs that individuals could access, all for prevention. So I think that would help. And that's my key message, is if we can have the supports in place, whether it's reaching out to your captain or you just going at home and looking into these resources to get help, then there will be no being off work. You can stay at work while you recover, like Diana highlighted as well. So
excellent, thank you.
Yeah. If I could add to that, I think, Diana makes a really good point, is these annual check-ins, and Alison just talked about that. And we've done a couple of test pilots. Well, we did a test pilot up at Fort St. John where we offered a mental health check-in with all of their members. And we actually used the CIPCERT, their self-guided assessment tools, to kind of benchmark them on, compared to other first responders right across Canada, their public safety personnel. And so showing where they are on the continuum, providing them mental health support right out of the gate. I think that's really, that's an awesome suggestion that Diana made, is having them be able to access multiple points of help and how to reach out, but also doing that annual deliberate intentional check-in, voluntary, of course, and then seeing, hey, maybe you need support, and getting them right upstream on that. So
thank you. I'm going to move to a question that was really kind of raised for the panel, but I'm going to direct it at Glenn because I think it may be particularly relevant in the policing world. But this is somebody who's written in who said, I'm currently off and have experienced judgment and stigma. How do we change the conversation?
What we've done here is we've been very intentional on creating buzz. And what I mean by that is having those people that have had their own struggles, that have been able to come back to work with strength and power and be the figurehead. And that's hard, to be the person that is the example of how this process can work. And we have had brave people that have come forward, that have come through our reintegration program, and both within the organization and external to local media, to say, hey, I did have a PTSD diagnosis, but I got myself back to work. And when you have those people that are willing to put themselves out there, that's where we change the conversation. I have one other thought on this, however. Overwhelmingly, if there's one thing I've heard from almost every single person that I've had the chance to work with, what they will say is, I just don't want this to happen to anybody else. They themselves have gone through a struggle, they've battled something, but they still have that greater sense of wanting to help their comrades in their profession. And so we can use that, and we can say, okay, how do we do this better going forward? How can we create a different conversation and use what they're saying, and in fact use them, if they're willing to be that person to say, I don't want this to happen to anybody else, and this is how we prevent these things from happening. Judgment, self-judgment, self-stigma is so quick to occur. And we also have to just really look at how we are changing the conversation. That's a big thing we're doing here. And one of the big things I say is that there is a massive divide between intention and impact. And that's the day-to-day conversations that we are trying to change here within Edmonton Police, which is, it's not just what I want to say, it's how that's getting perceived by the person on the other end of that conversation. And so when we spell it out that way, that's how we can change those feelings of stigma right off the bat. Let's look at communication a different way. There's a big difference between intention and impact.
Excellent. Thank you very much. Unfortunately, we're running out of time. I know I would love to continue this conversation, and each of you has so much to share on the topic. I'm going to ask you one closing question, and that is for each of you to have one word. So one word, which is your one piece of advice you would give to first responder leaders in leading a successful return to work. Allison, I'll start with you.
I'm glad I'm first. Collaborate.
Collaboration. Excellent. Thank you. Steve.
Damn it, Allison, you stole mine. It's 100% collaboration. But it's also, I go back to assets. Your biggest assets are your people.
Okay, thank you. So the recognition of the importance of these individuals as individual contributors. Glenn, your one word?
Control.
Control. Can you explain that a bit?
Our folks want to come back to work, and they often get barriers thrown up in front of them and walls. I think at every turn, at every decision point, we need to give our folks who are trying to come back to work as much control over the process as possible.
Excellent. Thank you. So it's not about the leaders having control. It's about the individual who's returning to work having control over the process. Thank you.
Absolutely.
Excellent. And Diana, I'm sorry you had to go last, but what's your one word?
Action. So to do something different. Everybody who's watching this session today has opportunity to do something different. So act on it.
Thank you. So unfortunately, that concludes today's webinar. I'd like to acknowledge every attendee for your commitment to first responder mental health. I'd like to thank today's speakers for their fantastic job. I'd also like to thank the great team who worked on putting these webinars together, from sourcing speakers to setting up the technology to registration and logistics. You can expect to receive a short survey in March regarding the series, but in the meantime, if you have any specific feedback on today's session, please send an email to info@bcfirstrespondersmentalhealth.com. Finally, I hope you'll join us next week for the fourth in our series, Silent Struggles, a look at stigma and comorbidities in the first responder community. Goodbye.